Testing.
Good morning, everyone. I hope you can hear me now. Good. All right. I received a message that you can't hear me. I'm going to put the video on so you can see me now. Okay, good morning. It's a pleasure to be with you all today. My name is Robert Cubeddu. I'm the president of the NCH Heart Institute, and I am delighted to have the opportunity to host this meeting today for you all. The idea of today's presentation is to hopefully bring you up to speed on a little bit of the contemporary developments that we've had in the field of valvular heart disease, which is really exciting. This is my field of work. I've been really devoted to this field over the last 15 plus years. I completed my training at the Massachusetts General Hospital and then subsequently moved to join the Cleveland Clinic, where I was chairman of cardiology. And then I was fortunate to join NCH Heart Institute here in Naples, Florida, approximately 2 years ago. So it's been a wonderful journey. We've done a lot of great work here in the region, and we've brought in really some spectacular new therapies for the region and our community, much of which I will share this morning, and hopefully you'll get to learn a little bit about what we do here at the Heart Institute and specific to valvular heart disease. So the heart is where we come to work every day, and it's a spectacular organ. As shown in this slide, it is 99% of it is really just a muscular tissue that has the ability to contract and pump in a very rhythmic and in a very organized way. This muscle that you see here, however, requires proper oxygenation, and that's what you see on the top. It's the coronary arteries. These are the little arteries that feed the surface of the heart with oxygen, and it enables the heart muscle to function and contract appropriately. When patients get a heart attack, exactly what that means is that those little arteries get clogged up from 1 minute to the next, and the heart suffers. The segment of the heart where that artery is no longer supplying blood to suffers, and that's what we call a myocardial infarction or a heart attack. So that's one of the most important, I think, anatomical elements of the heart is the coronary arteries and a healthy heart muscle. If we shift to the right side here, what you see is once we go inside the heart, we see the valves. And these elements here in white, the valves are very, very important to the heart function as well. There's a total of 4 heart valves, and these heart valves enable blood to circulate in one direction. So the valves open and contract with every heartbeat, and it enables blood to go from the deoxygenated venous system that then goes to the pulmonary arteries, and blood gets oxygenated. Once the blood is oxygenated by the lungs, it's dumped into the left side of the heart, and the heart then travels through the mitral valve and the aortic valve, which is behind the pulmonic valve. So there's a total of 4 heart valves, and obviously the heart function is incredibly dependent of the normal functioning of these valves. So there's a little video animation that kind of shows how the heart contracts. And when we go inside the heart, we can visualize how these valves function very nicely. As you can see, these valves largely depend on several structures, including the heart muscle, the little chorda tendinis, these valve leaflets. In some instances, we have valves that have 3 leaflets, other valves that have 2 leaflets. The leaflets are the compartments that open and close with every heartbeat. Um, so let's switch slides. So what is a heart valve? What is the role exactly? So basically what it does is allows blood to go from chamber A to chamber B. In black, you see the two valves, similar to any other valve mechanics. And so it naturally allows the blood to flow from one direction to the next, from one chamber to the next. But the fact is that valvular heart disease affects over 5 million Americans each year. These valves will degenerate. These valves can tear. These valves can become infected. There's different substantive disease states that can affect the function of these valves. And we see valvular disease most commonly in patients age 65 and greater, and that's due to wear and tear and degeneration of valvular disease. And believe it or not, valvular disease is one of the most common causes of mortality and heart failure in patients with heart disease. So not only heart attacks, as we explained earlier, but valve dysfunction, valve disease can eventually lead to heart failure, and the heart can fail, and with that, patients can ultimately demise. So how the pathophysiology of valve disease, or the disease itself, is actually quite simple. In simplistic terms, you could either have a valve that doesn't open well, and we call that an obstructed valve or valvular stenosis, or you can have a valve that leaks, and that's called valvular insufficiency or valvular regurgitation. These are all names that we use, and they imply the exact same thing. So when a patient comes to the office and says, my valve is leaking, or when a doctor says you have valvular insufficiency or valvular regurgitation, we're referring to the same entity. So in simplistic terms, this is kind of where the majority of patients, when they present with valve disease, it's either because the valve is obstructed or the valve is leaking. And valvular disease, as previously stated, these are all the different types of valvular disease. You see, we can have aortic valvular stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation. As you could see, once we peak in age 65 and above, the prevalence of valve disease really picks up substantially. And we can predict that almost 1 or 3 out of 10 patients age 65 or greater will have some degree of valvular disease. So what are the symptoms when the valves leak or when the valves become obstructed? Well, patients will develop shortness of breath, exercise intolerance, fluid retention, heart failure, and commonly this is manifested with the stethoscope by the presence of a heart murmur. A heart murmur is a noise the heart makes, and it's basically due to turbulent flow that occurs as blood flows through these valves, whether they're obstructed or whether they're leaking. When you normally hear a heart with a stethoscope, you shouldn't hear a murmur. You should just hear the valves open and close. So the presence of a murmur typically implies the presence of some type of valvular disease. And unfortunately, over the years, medications really do not help much when you have valve disease. And this is a generic statement. In some instances, diuretics and blood pressure medications can make valves function a little bit better, but we're really dealing with a mechanical problem that requires a mechanical solution. So pharmacological therapy or medical therapy is typically just palliative. It helps in some instances, but it doesn't ultimately fix the underlying obstruction or leaky valve that we see. So for the past several years, I would say 6 to maybe 8 decades now, the way we've treated valve disease historically is through an open heart operation. And some of the early founders of those procedures were really heroic in going into the heart, paralyzing the heart, opening the heart, removing those valves, repairing those valves. Because again, as I said previously, these are mechanical problems that require mechanical solutions. And sometimes valves can be repaired. Sometimes valves cannot be repaired and need to be replaced. And there's 2 types of valves that we use when we replace valves. You could either use a mechanical valve, as shown in this slide in dark gray or silver. A mechanical valve as such these are leaflets that are made out of metal. and they open and close. These little plates open and close with every heartbeat. Mechanical valves are good. They last a long time. The problem with the mechanical valves is that these valves tend to clot, and you need to put patients on blood thinners for the rest of their lives. So that can be an issue for patients. The other problem is if these valves ever fail, the only way to fix them is to go back in and take those mechanical valves out. There's no other catheter-based solutions, et cetera, that can be offered to patients. So we usually use mechanical valves in younger patients that have a very long life expectancies because they do last 30 to 40 years. On the other hand, once you hit age 65 or 70, we typically shift over to using biological valves or bioprosthetic valves. Those are the pig valves, the cow valves that you've heard before, I'm sure. So most patients actually, this is the valve of choice because typically they're age over 65 and older, and those valves will last approximately 10 to 15 years. The issue with open heart surgery is, as shown, is that, it's a very, very invasive procedure. And if you're 85 years old or 90 years old, this is probably the last thing you want done to yourself because it's a very debilitating procedure that requires a prolonged recovery. And these have been kind of the legends of the field. As a cardiologist of the 21st century, we owe a lot to these physicians, Dr. DeBakey, Dr. Cooley, Denton Cooley, Favillaro. These were some of the pioneers of cardiac surgery that really led the way. And we learned tons about valvular disease and how we correct these surgically. But over the years, we've recognized that there are many, many limitations to open heart, as we said previously. Not only cosmetics, but more importantly, the pain and discomfort, the requirement of blood transfusions, blood dyscrasias and disorders that occur with open heart, delayed recovery, prolonged hospitalization, wound infections. This series of limitations has really hampered our ability to treat every patient with valve disease with open heart, especially as the population continues to age. It's hard to subject an 80 or a 90-year-old to an open heart operation and not make it a really poor experience for that patient. So in an effort to overcome some of the early works of our legends, we've developed different techniques to try to overcome and minimize some of those limitations of open heart. And this is a slide that really shows what robotic surgery looks like and some of the other minimally invasive approaches that surgeons have taken to try to get into the heart and repair or replace these valves. So these are kind of novel solutions that are offered in several of the centers. We do minimally invasive thoracotomies and approaches to try to get into the heart. But one thing I want to remind everyone, this is still an open heart operation. You still have to stop the heart. You still have to get in there and replace the valve and resect the valve. So although cosmetically and perhaps less invasive, it's still considered an open heart operation. So the aortic valve, let's focus on that a little bit. The aortic valve is one of the main valves in the heart, and I would say probably one of the most prevalent conditions that we see in our office every day and here in Naples, Florida, is a condition called aortic valvular stenosis. And basically what that is the aortic valve is degenerated over the years. It's very calcified, very rigid, and the valve leaflets do not open. And this is kind of what that looks like. What you see in this slide is an ugly looking valve that has a very small orifice to it. And the rest of the valve is densely calcified. It's firmly fused. And this is what the heart has to work through. It has to pump blood, 5 liters of blood per minute, through this little small hole, an orifice. And so over time, the heart struggles, the pressures in the heart increase, and patients will eventually die from this condition because it is a slow progressive narrowing of the valve and restriction of the valve. So, and this is a slide that kind of shows the disease progression. The good news is that aortic stenosis is a slow progressive disease, and usually you could pick it up through a murmur, and with an echocardiogram, you're able to see the valve function and diagnose valvular stenosis. So when the valve becomes severe or critically stenotic, then it's time to replace the valve. When it's mild or moderate, we usually just watch it and we keep a close eye on it by repeating an echocardiogram every 6 to 8 months. So we've developed some really neat techniques. I've just shared with you that aortic valvular stenosis is highly prevalent in 80 and 90-year-olds. I've shared with you that open heart surgery isn't the best solution for these patients. And so what have we done? How far have we come, and what have we done to overcome this really challenging problem that affects millions of Americans and people around the world? So we've developed some really neat catheter skills that enable us to get into the heart through a catheter and replace valves without having to do an open heart surgery or without having to arrest the heart. And it's quite fascinating. And as someone who did the very first procedure in 2008 in the state of New England at Mass General, it's been incredibly impactful to see what this therapy has done for our patients and for the treatment of other valvular conditions, because we've learned a lot. And being able to replace a heart valve in a 90-year-old through a catheter approach in a beating heart is somewhat really revolutionized the field. And the man that deserves really most of the credit, or I would say the greatest credit, is Dr. Alain Cribière. He's a French physician who in 2002, 23 years ago, was heroic enough to take what he had tried in animals and tried it in humans. And so he took a catheter a valve that he had worked on in animal models and had patented and innovated, and tried it on a patient back 23 years ago, and this patient lived. This was a patient that was not a surgical candidate. No one wanted to touch him, and he was close to dying, so it was his only option. And thanks to Dr. Cribière and his early pioneer work, this field has now exploded. And we've learned tons from his early work. So this was one of the largest breakthroughs in cardiovascular medicine in 2002. Now, how did Dr. Cribière learn how to use catheter techniques? Well, we have to give credit to Dr. Andrea Grunzik. Andrea Grunzik was the first to ever take a catheter to the heart and fix one of the coronary arteries that had a blockage in it. So for many years now, for over close to 40 years, we've been using catheters to treat heart disease, but never had we used catheters to treat valvular disease. And that's the pioneer work of Dr. Cribière. So this is what a catheter replacement looks like. This procedure is called TAVR. It's now been available for close to, 13, 14 years. FDA approved in 2011. We did the very first case in 2008. So some of the pre-FDA approval studies, we were part of that. And it's just great to see how this therapy has evolved. TAVR stands for transcatheter aortic valve replacement. And here's a nice little video animation. Hopefully I can play this to show you what we do every day here in the hospital, or at least twice a week. Let's see, the videos doesn't seem to be playing, fortunately. Here. Let's see, it's not found. All right, well, we can try to come back to it later if there's questions. This is a picture that I took of a patient as I was doing the procedure. What you see here is really the groin. Right next to the genitals on the left and right side, we have the femoral artery on one side and the femoral artery on the left side. So it's two small cannulas that we use to cannulate the artery. And through this artery, we're able to take these catheters up into the heart and replace the aortic valve, as I showed here. This is the catheter that's traveling up through the aortic arch, and then we use a balloon to inflate the valve, and the valve is delivered. The native valve, the disease valve, is basically squished open as this balloon mediated valve inflation occurs. And this valve seals and closes tight on its edges thanks to the calcium bonds and the stiffness of the degenerative aortic valve. So that's what it looks like when we take the cannulas out. This is what it looks like. You have a very small, less than 1 centimeter incision. And this is what patients go home looking like. So you take a big open heart sternotomy and you turn that into a 3 to 4 millimeter nick on the skin. And it's incredible what we can now do. And these patients, most of them go home. I would say 98% of our patients are able to walk and ambulate and go home the next day without any discomfort or pain. So it's done under local anesthesia. It takes 1 or 2 days in the hospital, no pain, and success rate is as high as 99%. So quite remarkable. When we started doing these procedures, obviously the success rates were more in the 85 to 90% rate. But the catheter technology has improved such, and the skills have improved such that we're able to do these within an hour's time with great success. So we're now treating 100-year-old patients at times that present with aortic stenosis, and in this case, we let them smoke a little longer. The mitral valve is another area of expertise that I'm very passionate about, and before I jump to the mitral valve, just maybe a sentence or two on our aortic valve program. We're the busiest TAVR program in the entire Southwest Florida. When we joined the organization here 2 years ago, we really ramped up the program, its volume, its quality, and we do close to 200 TAVRs a year. That's approximately 4 or 5 cases a week. So it's quite remarkable. We're very proud of the results, and our numbers are pretty much better than national average in what's reported in terms of perioperative complications. And having pioneered this work over the last 15 years has really allowed and enabled us to perfection these techniques and these skills. So we're really kind of proud of those results. So the mitral valve is another valve that's very, very prevalent. Opposite to the aortic valve, however, the mitral valve tends to leak. It doesn't tend to obstruct, it tends to leak. Mitral stenosis does occur, but it's less common. Mitral valve regurgitation or mitral valve leak is far more common. So again, and this is what it looks like. Here you see a leaflet that's torn, and you see a blush of blood that's going back from chamber A to chamber B, and that shouldn't be the case. Blood should always flow in one direction. And patients with mitral leaks will get similar symptoms: shortness of breath, fluid retention, heart failure. And with time, the left ventricle, which is the main pump of the chamber of the heart, will dilate and progressively become affected. So this is a video animation that shows the leak. You see the valve leaflets aren't closing well, and you see a blush of blue blood here going back into the left atrial chamber. And that's what we call a mitral regurgitation. This leak is what causes the murmur, the noise that you hear on the stethoscope. So we've had, very similar to the aortic work, incredible amounts of efforts being developed in this field to how do we treat and repair these valves without open heart surgery. So these are all transcatheter solutions that are in the pipeline, many of which are still under investigation, a couple of which are now FDA approved. The one that we have available and that's FDA approved is the mitral clip. This is a really neat, technology. Let me go back a slide because I think we can play a video here to show it. So it almost looks like a little robot. It's got all these cannulas and side ports and knobs that enable us to take the catheter up into the heart. Through the vein, we puncture one of the main walls of the heart, and we then steer the catheter over the mitral valve. Again, this is in a beating heart. A clip is then advanced through this catheter and navigated towards the left ventricle through the mitral valve. And you can see here how we're able to kind of negotiate the clip perpendicular, parallel, medial, lateral. We can orient the clip in many directions, and this enables us to position the clips specifically in the area where the leaflets are not touching, they're not coapting. And by doing that, we're able to, in many instances and successfully, clip the two leaflets together and eliminate the leak. So imagining kind of doing this in a patient who's, again, 80 plus years old, who's struggling with a leaky valve, and being able to do a minimally invasive procedure through a catheter to eliminate this leak. Again, another kind of remarkable, innovative solution that's now been available for the last about 10 years or so for our patients. So quite remarkable. This is a kind of a real image of a patient that we did recently. You could see the clip in position. You could see the thickened mitral valve leaflets, and we're basically clipping in real time these leaflets as the heart is contracting. And then we're able to measure in real time the immediate results and effects of the mitral clip. So very impressive procedure. It was FDA approved back in 2013, and we're now offering this to our patients here in Naples. We're the only program in Collier County and one of the few here in Southwest Florida, and our mitral clip volumes have really exploded. We're probably second or third in the state with really remarkable outcomes. We've had 0% in hospital mortality, and most patients will go home the next day. And I won't bore you to death, but there's a lot of other stuff coming out in the pipeline. These are fully replaceable mitral valves. Again, catheter-based solutions to replace the mitral valve rather than repairing it in instances where the clip perhaps is not a good solution. So here we see a fully replaceable mitral valve done through a catheter without the need of open heart surgery. In the case of the tricuspid valve, another very prevalent leaky valve that we see, and we now have access to this spectacular valve that's a fully replaceable valve of the tricuspid valve. This is still under investigation, but we're one of the only few sites in the entire state and only one of about 50 in the country that has access to this technology. Just yesterday, we did a case of a patient who had severe tricuspid leak with significant right-sided heart failure. They had bloated abdomen, significant fluid retention in their legs, and it was because that tricuspid valve was leaking terribly. So we had no solutions, and surgery in this case is not a good option. So these patients historically have been left untreated with medicine. And we know that medicines really doesn't do much for solving the problem, at least. So this is what the fully replaceable tricuspid valve looks like. It's an incredible procedure. And again, it's done through one stick from the groin, very controlled, and you get really spectacular results. So the patient we did yesterday, I heard this morning he's doing great and that he'll be going home at noon. So quite remarkable. Again, we were the first in Southwest Florida to do these procedures, and we really have a spectacular team. This is not about me. This is really about the team that we have here. Couldn't do this without the support of our research institute, as well as my colleagues, my staff, the nurses, even the reps that come from these industries to support our cases. So, really exciting. This is really, I guess, a 30-minute presentation about valve disease. I had a few more slides on other things that we're doing in the heart with catheters. Many of you have heard of the Watchman procedure, perhaps, but this is a device that we put in the left atrial appendage to prevent strokes in patients with atrial fibrillation. But I guess to be respectful of everyone's time, I will kind of stop there and maybe take some questions. This slide just depicts really what has occurred over the last 15 to 20 years in the field of structural heart disease, which is what I do, which is all these catheter-based solutions to prevent stroke, to treat valve disease, to fix coronary arteries. It's quite remarkable and exciting. So percutaneous or transcatheter therapies, I think, have really, with the turn of the century, have really taken a large, national stage on how we treat a lot of the conditions of the heart. And While we're incredibly grateful for our surgeons and the work they've done over the years, it's great to be able to offer these therapies to patients as it offers them a much better outcome prognosis and recovery. So this slide just reminds me of maybe what you've heard in the community, our vision. We're really excited to lead the Heart Institute here in Naples. These are some preliminary 3D renderings of the future of the Heart Institute and what that looks like. And so we're really excited kind of to be here and to have the opportunity to speak to you all this morning. So thank you very much for your attention. I'm happy to take any questions. I hope this was helpful and instructive. I think there's a chat in case any questions want to, you could type your question and hopefully we can address those. Let's see here. Well, thank you for the remarks. We are getting some chat messages. Very informative. Thank you. Very helpful presentation. So I'm happy to hear that. Can a previously replaced aortic valve with a bovine valve be replaced with a minimal incision? So that's a great question. So the question is, if you've already had an open heart and you have a pig valve or a cow valve that's now degenerated, is there something that we can do without having to do another open heart? And the answer is yes. We can actually do another TAVR inside a degenerative biological pig valve or a cow valve. So in patients, and we see this often, patients that have had prior open heart with valve replacements, as long as the valve is not a mechanical valve, the valve is a biological bioprosthetic valve, then yes, we can go in and put a valve inside a valve. It's called a valve-in-valve TAVR. And we could do that as well for the mitral valve, as long as it's a biological valve. So that's some of the that's some of the new advantages of these pig and cow valves, is that it enables you to have a transcatheter solution in the future if, God forbid, that valve degenerates or deteriorates. It's a great question. Let's see if there's any more questions. How do we get an appointment to see the doctor? Well, that's a great question as well. And let me see if I can find the phone number here for the Heart Institute. I don't know it off the top of my head. Well, I should. And I will put that in the chat soon. Here's another question. What are the infection rates with these transcatheter repair solutions? So infection rates are kind of low. They hover in the less than 1% to 2% range. But infections are important, and we address these every day with our patients when they see them in the office. How do these valves become infected? Typically, they become infected when you go to the dentist, you have dental cleaning, and the dirty gums and the bacteria that lives in your mouth spills into the bloodstream, and then these bacteria love to attach and adhere to these valves. So the way we prevent valve infection is we highly encourage patients to take antibiotics prior to any dental work that's done. And that's why if you've had a pacemaker, if you've had a foreign body inserted in your heart, including one of these valves, we remind you to take antibiotics an hour before your dentist visit. So very important. And as long as you do that, the rates of infection are probably much less than 1%. And when these valves become infected, it is a bad problem. The comorbidities and the outcomes of patients with infected valves are not that good. So I'm typing the Heart Institute phone number. I generally do valve work. I'm not an expert in general cardiology and the management of high blood pressure, cholesterol, and other stuff, but we have certainly many cardiologists in our group, and many of whom are new and have open slots available that can take in any patients from the community. If you do have valve condition, coronary disease, complex heart disease, I'd be super delighted to see you in the office. So um, that is the number for the Heart Institute. Okay, let's see if there's any more questions. I think that's it for now. Okay, good. Well, I want to thank everyone again for participating this morning. I'm glad it was informative, and we look forward to doing these. What is it, once a week, once a month? Are we doing these, or? I think there's another one of these speaker venues coming up in the near future with Dr. Navas, and she will be speaking about heart failure and the management of heart failure, which is really exciting topic. So thanks again. Have a good day.